So endometriosis is a condition where endometrium, which is the lining of the uterus, is found outside the uterus. So it may be found on the peritoneum, which is the lining which covers the abdominal cavity. It may be found on the ovaries, on the septum between the vagina and the rectum, on the bladder. It can even be found in the peritoneum near the diaphragm.
So symptoms from endometriosis can vary so much from one woman to the next. Now, Dr. Doyle, why do we get this wide range of symptoms? What problems do women with endometriosis face?
Yeah, endometriosis is a real chameleon of a disease. Some women have absolutely no symptoms, and you're doing a surgery for other reasons, and you find an enormous volume of disease. Some people have significant pain, and so that's how they present. And then there's even a group of people who present just with infertility. You can also see kind of combinations of those things as well.
So pain, infertility, or even no symptoms at all?
Yeah.
And are there effective treatments for infertility with
Oh, absolutely. And we'll talk about a lot of those.
Okay, great. Now, pain is something that you've been specialising in, Dr. Sika. Tell us, and that pain can be very severe, but are there effective treatments available for the pain of endometriosis?
Oh, absolutely. Absolutely. There's a lot which can be done.
So give us a bit of a range of what that might entail.
Right. It includes treatment modalities, including surgery, in which we resect the endometriosis, and medications to suppress endometriosis long-term, and other therapies like pelvic floor physical therapy, pain management.
So a whole gamut. And you drive a very expensive robotic laparoscope. How much are those, by the way?
I would say $1 million, but don't take my word on that.
So around $1 million, and we're going to see you driving one of those later in the show. That's great. Thank you. Today on Go Healthy for Good, we're discussing endometriosis. We mentioned earlier that Dr. Sika operates using a highly sophisticated robotic platform called the Da Vinci system. We call it a robot, but she is totally in control. As she sits at the console, she interacts with a 3D image of the surgical site and does the surgery remotely. Across the room, the computer seamlessly translates her hand movements into precise micro movements of the instruments inside the abdomen of her anaesthetized patient. We have a clip of her operating now. Watch for the tiny red spots of peritoneal endometriosis on the pelvic sidewall before she removes them, along with an area of peritoneum.
The surgery for endometriosis is minimally invasive. It is done through small incisions on the patient's abdomen. This is the Da Vinci robot. And here you see the robotic arms have been attached to the patient through small cannulae which are present in the patient's abdomen. And here you see me sitting on the console. And once we look through the console, we see a three-dimensional, very magnified view of the patient's abdomen. And this is what the inside of the pelvis looks like. Here we see the uterus, the left ovary, and the bowel. And here the left ovary is being lifted up. And we are actually going to zoom the camera in below the left ovary and focus on these endometriotic implants, which are looking as bluish spots on the left pelvic sidewall. Now, this patient is a 32-year-old who presented with severe left-sided pain, which occurred with menstruation and with sexual intercourse. We just actually burnt one of the endometriotic implants, and we are starting the resection of the peritoneum on the left pelvic sidewall. Now, because this patient has multiple lesions of endometriosis, we are actually resecting the entire left pelvic sidewall peritoneum to include removal of microscopic disease. Now, here you see that the left pelvic sidewall peritoneum has been completely resected, and now the ovary is freed. And you can see both the ovaries and the tubes and the uterus. This patient went home the same day after surgery and then returned to work in about 10 days.
That's a very sophisticated device, beautiful to watch. By the way, that peritoneum will grow back very quickly without any scarring. Continuing the discussion now are our two guest gynecologists, Dr. Sika, a laparoscopic surgeon, and Dr. Doyle, an infertility expert. Dr. Seeker, you've brought a lovely model for us to have a good look at the pelvis today, but tell us, where does endometriosis grow? You were mentioning some of the places, and perhaps our viewers didn't understand all of those words, so just show us on the model.
Okay, so the endometriosis may involve the ovary, and it can form like big cysts called chocolate cysts in the ovary. It can involve the peritoneum, which is the lining of the abdominal cavity. It can involve the peritoneum over the bladder, or the peritoneum between the vagina and the rectum, or actually peritoneum anywhere in the abdominal cavity. And it can also be deep infiltrating endometriosis when it involves the uterosacral ligaments, which are in the back of the uterus, or it can involve, again, the ovaries or the bowel right here, or even the bladder in the front.
Now, you can even get endometriosis in bizarre places like brain or lung.
That's right.
Yeah.
You know, I've heard of women having a nosebleed every month.
Right.
Where have you seen what's your most bizarre case?
The most bizarre I've heard is, and like you say, it can create these unusual symptoms, but a woman who had it in her lungs, and so once a month she would cough up blood.
Yeah.
And it was, of course, very uncomfortable, and you can even get, blood developing in your lungs. And fortunately, even when it's bizarre situations like that, the medical therapies generally do a great job in suppressing it.
True. I've seen it myself in a cesarean section scar quite a number of times. Where else have you seen it?
I have seen it in the umbilicus, in the belly button, and the patient used to have periods right from the belly button, and we excised it.
Yeah, yeah, I've seen that too. Yes, so very interesting. And in when after having a baby, there's sometimes you get a tear or a cut and a scar, and I've seen it in the scar as well, on the cervix. So all sorts of places, but we're talking about the common ones here.
That's right.
So why are those places on your model most at risk?
Okay, so this brings us to why does endometriosis occur, and one of the theories for endometriosis is called retrograde menstruation. Menstruation means when the menstrual blood comes out and it's normally expelled out of the body through the vagina. In retrograde menstruation, this blood comes from the tubes and it comes actually into the pelvis. And now this menstrual tissue can implant in the pelvis. It can implant on the ovaries right here, it can implant on the peritoneum, and it can involve even the bladder right here, or the bowel. And so that's one of the most common theories, which sort of tells us why it's commonly found in the pelvis, in the vicinity of the uterus.
Right. It doesn't explain why it might go to other places in the body, and I don't know. There are theories out there as to why that happens.
Yeah, there are a number of theories, and the retrograde menstruation one is certainly the most widely held one. But then, at the same time, they say half of women at least will have that present in their pelvis. So why don't half of women have endometriosis? So there's got to be something more to it than just purely that part of things. And so
it must travel in the bloodstream or in the lymphatic system, or some other way to get to these bizarre places around the body. It's very rare, but still.
Right. But there must be more than one single explanation for this.
Yes, yes, that's right. So every month, the endometrium, or the lining of the uterus, spills into the peritoneum in all women. And those cells are destined to die and be gobbled up by the immune cells called phagocytes. So, Dr. Doyle, what goes wrong? Why do some women, those cells will actually fall down, but then implant and grow?
Right, and that's an area of huge research on this topic. We're trying to get to the bottom of why is there the alterations in the immunity allow this process to develop and cause these symptoms. You can see there's certainly differences in inflammatory markers, the profile in the pelvis and the pelvic fluid, just the peritoneal fluid. You see differences in the populations between those who do and don't have endometriosis. So there's certainly some altered immune function, and even the phagocytes themselves, something's different about them, so they're not doing their job like they typically do.
So These immune cells are cruising around inside the abdominal cavity in the peritoneum, chasing down rogue endometrial cells, which have no right for being there. But you know, Dr. Seeker, those cells inside the uterus are painless, yet you put them outside. They're very painful for some women. Why is that?
Right. So these endometrial cells, once they come outside the uterus and are not attacked by the immune system because of immune dysfunction, these cells, for some reason, start producing inflammatory substances or mediators which cause pain, like prostaglandins, like nerve growth factors. And these substances stimulate the pain receptors and actually can also sensitize the spinal cord and the brain and make the patient feel more pain. That's why.
So it's a lot more than just localized in the pelvis. This is involving almost systemically a whole process. Now, tell me, you're in the business of treating pain with endometriosis. Let's pretend we'll take a patient, we'll call her Jane, and she arrives in your office with chronic pelvic pain. What's the first thing you're going to do with her?
Well, sit down with her and take a good history.
And you'll be asking specifically for what kind of things?
Well, in a pelvic pain patient, the history starts with how long she has had pain, what is the type of pain, where is the pain located, in the abdomen, one side or the other side.
And if she has endometriosis, what would be some flagging pain type pictures?
Patients with endometriosis have severe pain with periods. Their pain with periods may actually start before the onset of the period, continue throughout the period, and may even persist after the period. The pain may be localized to one or the other parts of the lower abdomen, depending on where the endometriotic lesions are located. These patients may also complain of severe pain with sexual activity, especially with deep penetration, especially if the patient has deep infiltrating endometriosis involving the rectovaginal septum. Patients may have back pain or just persistent lower abdominal pain and a feeling of heaviness if they have large ovarian endometriomas.
And one thing you can appreciate from all these different symptoms is it is, like I was saying, it's a chameleon of a disease earlier, and everyone can be, it's important that you really look at this broadly because a lot of these symptoms overlap with other things. So endometriosis is one common cause of pain, but you do have to look at the whole patient and consider all the pieces to it.
Right. So you take a history, it sounds typical, then you examine your patient. What are you likely to find if there is endometriosis there?
It really depends on the extent of endometriosis. Patients who have moderate to severe endo, like patients who have large endometriomas, rectovaginal nodules, the exams are very tender. And, these patients are patients who have avoided sexual activity for this reason. And patients who have mild endometriosis may have a very normal pelvic exam, or if they have some involvement of the uterosacral ligament, you might be able to feel thickening and tenderness behind the uterus on a vaginal exam.
So Jane's in your office and you're going to order an ultrasound scan. What might you find, or what might you be looking for on a scan for endometriosis?
Well, a scan for endometriosis may show large chocolate cysts of the ovary or ovarian endometriomas. And that's primarily what it might show, because mild to minimal endometriosis will not be picked up on the ultrasound.
So, Dr. Doyle, is there any blood test that we can do to help us in this diagnosis?
Unfortunately, there's not really a blood test for endometriosis that gives us any additional clinical information, and that makes it harder to diagnose. It's really a surgical diagnosis.
There are some tumour markers, though, some biomarkers, and they're developing some new ones, so maybe a CA125 or CEA. Do you use that?
CA125 is very tricky. It can be elevated in a number of benign conditions like fibroids, adenomyosis, several GI conditions. It's not a good marker to use in premenopausal women. It's a good marker to use in postmenopausal women when you are screening for ovarian cancer.
So you're not using the CA125?
No. Yeah.
Okay.
Yeah.
Now, how do you decide which type of treatment to use for the different types of endometriosis that you've been talking about?
So the type of treatment really depends on patient's symptoms and patient's desire. So if a patient is desiring fertility and has pain from endometriosis, in that case, we'll go ahead and perform a laparoscopy and look inside the pelvis.
Which is what we saw on the video. Yeah,
Yes.
what you're
And
doing.
right. So, just as we saw in the video, we actually removed endometriosis in a case of mild endometriosis on the pelvic side wall, but the patient was very symptomatic because these endometrial lesions were producing these chemical mediators. Now, if patients have severe endometriosis and have pain, we'll still go ahead and do surgery. Now, if patients have no symptoms from endometriosis, they just have endometriomas, they say small endometriomas, and have been trying to get pregnant, haven't gotten pregnant, then I refer them to a reproductive endocrinologist for their opinion, because these patients may or may not need surgery depending on what the infertility specialist thinks.
And that's where we work pretty closely together. We have physicians who present to us first and ultimately end up getting surgery with someone like Dr. Siga, or it can happen also the other way around, where someone with endometriosis, we end up working together from their end to us. So it kind of flows both ways.
So what would you do then? Let's say no surgery was required. What would you offer from an infertility perspective?
So if this is completely an asymptomatic patient, there's we were talking about endometriosis on the ovary. That does make it a higher stage disease. And people with higher stage disease have greater challenges to overcome to achieve a pregnancy. People with very mild disease, even where it's just suspected, you don't see anything, but their diagnosis maybe might be suggested by something in their history. There's some very, very conservative treatments that will give them that little boost, because we know it does impact their fertility.
So what might they be looking at for that?
So, sometimes when they come from Dr. Sica, if they've had a laparoscopy already for pain, the surgery does improve pregnancy outcomes. Typically, though, if you have someone who, with just pure infertility, no surgical diagnosis at that point, it makes sense just to proceed forward with, for minimal disease, you just do IUI therapy, which is just a mild stimulation of the ovaries, and combine that with just essentially getting the timing of the sperm being present right when ovulation happens. And we know that pregnancy rates are better there.
And that's not costly, it's non-invasive, and
Right.
so that's great. And I presume you'd use IVF for more advanced?
Yeah, IVF is safe for really the really ground-in disease. So, the endometriosis population, typically you see about 4% pregnancy rates per cycle. The first step would be that IUI treatment, and that usually gets success rates somewhere around 15 to 20%. That's for mild disease. Now, if you have really severe disease, that's not a great treatment option. IVF, though, is significantly more successful. We know that endometriosis still hurts success rates somewhat, but it's certainly the best treatment option for really severe disease.
Having had surgery, it's really important that you prevent the disease from coming back, which it tends to do. So Dr. Sica, what's your favourite preventer after you've cleared the pelvis of endometriosis and you want it to stay away?
So there are several different options the patients have. They can start oral contraceptive pills, which have estrogen and progesterone. The idea is to make the patient amenorrheic, so she doesn't get a period. And it shows significant improvement in pelvic pain. Then a device called the Mirena, which is actually, it's an intrauterine device which can be placed inside the uterus, and it just sits in the uterus like this and has a thread which is in the vagina. And this device can be placed in the uterine cavity very easily, just in an office visit. Just takes like maybe 2 minutes to put it in. And it produces levonorgestrel, which is the progesterone, which mainly affects the uterus and the surrounding tissues. Very little does go into circulation though. And many patients don't even have a period on the Mirena. Those who do may experience some breakthrough spotting and bleeding. And studies have shown that Mirena causes symptomatic improvement in these patients and also causes suppression of endometriosis.
Yeah, it's a very effective treatment, and the beauty of it, I think, is that you don't get a lot of progestogen on board. It treats just the local area. So you've got the pill, you've got the Mirena intrauterine device.
Right, and then we can give them oral progesterone as well, like norethindrone acetate has been shown to even suppress colorectal endometriosis.
So that's like the Mirena, but taking it systemically.
Exactly.
So that you can treat a little bit further away.
Right.
Excellent. Now we also know that a healthy lifestyle is essential for a functioning immune system, a well-regulated inflammatory response and healthy hormone levels, which are all important for endometriosis. So let's see, what lifestyle factors might you encourage your patients to take up, and what things might you want them to modify to keep their endometriosis away?
Well, you know, the studies show that there is immune dysfunction involved in endometriosis. We don't have data to support any dietary guidelines or any lifestyle modifications in patients, to my knowledge so far. But, you know, anything which can bolster the immunity, you know, a healthy diet, exercise, you know, sunlight, multivitamins, you know, to make a patient healthy.
And what about for infertility, Dr. Doyle?
Well, for infertility, you know, a lot of those things, we know exercise and a good normal healthy body weight. So not being too heavy and not being too thin either. Both sides of the spectrum are important there. Both how it relates to endometriosis and infertility in general. We know some of the risk factors for endometriosis, which also overlap with infertility, are consumption of alcohol, smoking is a risk factor for both infertility and endometriosis.
Yes, smoking can really impact the immune system, can't it?
Absolutely. Right, ties right in beautifully with that. Having a very low body weight is a risk factor.
Right,
For
and
endometriosis.
over-exercising is an association,
Yeah,
isn't it?
they found an association. People who exercise more regularly have a lower risk of endometriosis. So just another good plug for a good active lifestyle.
And I was also reading that shift work it doubles or even more, increases the risk of endometriosis. Doing night shift for more than 5 years, and when you're on your nights you sleep during the day, but then when you come off your nights you sleep at night. Doing that will actually increase the risk of endometriosis, I was reading. So
Yeah,
it's
interesting.
they found a bunch of interesting with shift work. It must change physiology enough because it's linked it to a number of diseases, curiously enough.
Yes, it is. And you're just about to have a baby, so you're just about to start night shift every night.
Oh, boy.
And I want to wish you well as you become a father for the
Appreciate
first
it.
time.
Thank you.
And Dr. Schober's a seasoned mother with 2 children. But I want to thank you so much for coming on the show. It's been great having you here. You're a mine of information. And I wish you well driving that $1 million machine.
Oh, thank you.